Good afternoon and welcome to this presentation on prostate cancer, sponsored by the Jamaica Cancer Society and the Brothers United Against Prostate Cancer. The month of September each year is designated as Prostate Cancer Awareness Month. It is said prostate cancer is the largest killer of men in Jamaica, and it particularly affects men of African descent. You'll hear more of that from our presenters. We have two urologists set up to invited to be part of this webinar, Professor William Aiken and Dr. Robert Wan. Professor Aiken is an old boy of Calabar, and Dr. Wan is an old boy of Kingston College. But because we're not champs, we are united in this effort to fight the common enemy, prostate cancer. It has been a little difficult for us this year because COVID-19 has overshadowed most other medical conditions, but we still want to bring the focus, certainly for this month, and really it should be for every month, on prostate cancer, since it is a disease that can be cured and we don't have to die from it. When I was a youngster, the word cancer was met with a big shh, no one wanted to speak about it. But today we want to make people aware that prostate cancer does not have to be a killer. And that is why we have taken the effort, the Jamaica Cancer Society, along with the Brothers United Against Prostate Cancer. I'm a member of the Brothers United as well. And we are determined to get the word out, to get our men to go and have their prostate cancer checks done in a timely manner. And that's why we are also focusing on the women. We want our women to encourage the men in their life, whether they're fathers, brothers, boyfriends, husbands, cousins, because men generally do not like to go to the doctor. We have this fear of finding out what is wrong with us. And so we are encouraging the women to help the men to pay attention to this very important part of their health, to get screened for prostate cancer at the age of 40. I'm a survivor of 18 years, and I'm alive today to tell the tale that you could not tell if you saw me that I was a prostate cancer survivor. I think I caught it just in time. And so today, 18 years later, I can celebrate and say, thank God that I'm alive, and thank to those, my doctor and those who cared for me. And so without much more, I would like to hand this first session, and introduce Mr. Michael Giardini, who is the president of the Brothers United Against Prostate Cancer, to speak about that grouping of men. And there's two urologists are involved, one is female, and that grouping of men who are concerned. And so we want to help folks when they find that they have cancer, and we will help them to walk them through with their concerns and to support them in their fears, for want of a better word. And so I'll hand it over to Mr. Michael Giardini about now. Okay, over to you, Michael.
Thank you very much, Deacon Clive and fellow brother in our organization. Good afternoon to everyone. And basically, I would like to, first of all, say it's an honor to be chairperson for this, what I'd want to believe is a very noble grouping of people. The mission statement for Brothers United Against Prostate Cancer, a group that was actually formed in November of 2019, but it had its setbacks based on COVID. And as the moderator said, all other health fears seem to have been pushed aside, but we have to refocus. Life goes on, and we remain positive. The mission statement for Brothers United Against Prostate Cancer is to provide a nurturing environment for Jamaicans interested in addressing the physical, spiritual, and emotional issues surrounding prostate cancer survival, thereby advancing men's health and ability to live fruitful lives. Our vision statement defines, our vision statement, defines what we want to be, of course, in the future. and that is to be the leading prostate cancer peer support group in the Caribbean within the next 5 years, providing, sorry, I can't read my own writing, by providing insightful educational awareness, spiritual grounding, and medical caregiving options that will empower and equip persons to have a positive outlook on life. So those two are our mission and vision statements. We really, as you say, are a peer support group. We want to be speaking to recently diagnosed patients of prostate cancer. We'll share certainly with the people, the families, and the caregivers in their lives who play such a critical role. And we certainly want to be there, as the moderator mentioned, to offer any kind of help. The one we can't guarantee is financial, but in every other area of your life. I too, like Clive, I'm junior to Clive. This week I'll celebrate God's Spirit in our lives. Well, my life will be 11 years as a survivor of prostate cancer. And thankfully, I was proactive. And thanks to God, thanks to my family and friends who supported me throughout, we're here to be speaking in this very, very important forum. What we have been doing, and we have recently done at Brothers United Against Prostate Cancer, is to set up an Instagram page, an Instagram address of Brothers United, and it's the same thing on Facebook, Brothers United. You just put your messages there. We will respond as best as possible. And if you're ever in doubt how to find us, if you're not tech savvy, as I am not the greatest in that area, feel free, call the Jamaica Cancer Society. They'll put you on to us. We have presently a group of about, I would say, 12 or 13 survivors that we can sort of say, okay, this is where you are, this is your experience. We can put you with one of them, and they're all very, very willing to share their experiences. Some of many, many years like Clive, and some of lesser years than myself, and some very recent ones. I can speak to someone who, in the last 2 months, we have 2 people that are with us who are so willing to share their experiences, which have all been received quite positively, the treatments and response to those respective treatments that they have selected. But I could not end without really imploring everyone here to be evangelists. Speak to every male you can who is 40 or above or approaching, and especially those that you know have a history of in Jamaica here. Boy, I heard my grandfather had stoppage of water, any kind of disorder like that. Please implore them to have screening done. Thank you again, Mr. Moderator, and we'll be here to answer any questions later on. Thank you.
Thank you, Michael, for that that bit of information, which is most important as well. We have a very tight schedule, and I want to waste I don't want to waste any time, because we want to find out as much as we can about prostate cancer. And so today at the moment, I'm gonna introduce Professor William Bill Aiken, who will speak about, the topic is Let's Talk About Prostate Cancer. And Dr. Aiken was trained at the University of the West Indies. He completed an MBBS degree in 1989 and a postgraduate degree in neurology in 1998. He became a fellow of the Royal College of Surgeons of Edinburgh in 1995 and was awarded a Commonwealth Scholarship in 1996 to do a one-year elective in urology at the Western General Hospital in Edinburgh, Scotland. He's the first graduate of the UWI Doctors of Medicine program in urology and was mentored by Professor L. Lawson Douglas. He has served as president of the Jamaica Urological Society, the Caribbean Urological Association, and in the immediate past, and as the immediate past president of the Association of Surgeons in Jamaica. He currently serves on the Medical Council of Jamaica and was recently made an international surgical advisor for Jamaica by the Royal College of Surgeons of Edinburgh. The promotion of to the rank of professor recognizes Dr. Aiken's academic achievement and leadership roles in surgical societies. He has made innumerable academic presentations locally, regionally, and internationally. Professor Aiken is a fellow of the Caribbean College of Surgeons, the American College of Surgeons, and the Royal College of Surgeons of Edinburgh, and is also an associate editor for the Journal of the Caribbean College of Surgeons. In addition, Professor Aiken is my urologist who did my surgery. And when I remember one of the things that one of his peers said, he prides himself on his surgery. And I know he's a very, very good and caring person. And so I would like to turn over this portion of the webinar to him. And we are just going to ask you to send your questions, if you do have, which we will have, we'll ask at the end of all the presentations, okay? So we'll keep the presentations flowing. So I now hand you over to Professor Aiken.
Thank you, Deacon Clive Chambers, for that lovely introduction. And let me say welcome to all the participants on the webinar today, and to especially thank the Jamaica Cancer Society for affording us this opportunity to have this conversation around prostate cancer. And also to thank Mr. Giardini, or chairman from Brothers United Against Prostate Cancer, for leading the charge and for his words earlier. And I certainly want to support what he said in that we need to become evangelists, and especially the ladies out there, the mothers, the wives, the girlfriends, the sisters, and encourage our men to come in beginning at age 40 for screening. So today we're going to be having a conversation about prostate cancer. And the first place to start is to get an idea of what the public health burden of prostate cancer is, not only in Jamaica, but the Caribbean. Up until a couple of years ago, the Caribbean had the highest death rate from prostate cancer in the entire world. It is just recently that sub-Saharan Africa has overtaken us, and we are now in the number 2 position. Globally, prostate cancer is about the 4th or 5th commonest cause of death. So you will recognize that in a country like Jamaica and the rest of the Caribbean, where it is the number 1 leading cause of death, not only among men, but in overall, you recognize that prostate cancer presents a serious public health burden. The incidence of prostate cancer can be manipulated by screening. In countries that screen a lot, you'll have a higher incidence. But it is a death rate, the unnecessary death from prostate cancer in our population that really emphasizes why we consider it such a serious problem, and why webinars such as this are so important for educating Jamaicans, men and women, about the unnecessarily high death rate from prostate cancer. So what is the prostate? Before we talk about prostate cancer, we have to have a good understanding of what the prostate gland is, where it is located, what function it serves. Can a man live without it? And if a man loses his prostate, what is he unable to do? So the prostate gland is what we call an accessory organ of reproduction. The primary organs of reproduction in the male are the penis, which is the organ of copulation or intercourse, and the testes is the organ that produces the male cells, the spermatocytes, and the sperm cells that fertilizes a female egg. And so these are the primary organs of reproduction. There are some other organs like the prostate that plays a supportive role or an accessory role, and are equally and just as important in reproduction. In the case of the prostate, its roles can be categorized under 2 broad headings. It has a secretory role and a muscular role. So prostatic secretions are acidic, and it makes up about 20 to 25% of the semen when a man ejaculates. the overall pH of semen is alkaline, and that's because secretions from another organ called the seminal vesicle, which contributes 70% of the volume to semen, that secretion is alkaline. And so the overall pH of semen is in fact alkaline. But prostatic secretions are acidic, and it has a number of constituents that provide and that play a number of roles. One, it has an antibacterial role in that the secretions of the prostate helps to prevent infection. And an important mineral, zinc, plays an important role in one of the enzymes, prostatic antibacterial factor, that helps to keep urinary infections and prostatic infections at bay. But the prostate secretions are also rich in a lot of sugars and other substances that support the sperm cells as they make their journey in the female genital tract. So the secretions from the prostate has this supportive role for the sperm cells. There is also a substance in PSA, which we're going to be talking about, called prostate-specific antigen, which is an enzyme that keeps semen liquid, so it allows it to flow freely in the female genital tract. So those are the secretory roles. But the prostate also has a muscular role in that during ejaculation, the prostate contracts and it pinches off the connection with the neck of the bladder. This would be, and that pinching off of the communication with the neck of the bladder prevents retrograde ejaculation. It prevents semen from going back into the bladder. This would be a good point at which to look at a diagram of the prostate. So I'm going to now share my screen and find a picture of the prostate that I would like to share with you so that you can have an idea of what the prostate looks like. Okay, so it's coming out sideways. Okay, here we go now. So this diagram demonstrates the prostate. This is what we call a sagittal section. Imagine you cut a man right down the middle, and you're looking at the belly button or the deep bony pelvis. At the front, you see the pubic bone, which is that bone that you feel just above the root of the penis. You'll notice that immediately behind that bone, you have the bladder sitting atop the prostate gland. The prostate gland is located immediately in front of the rectum. So you're looking at this diagram, you realize that the prostate gland is immediately behind the pubic bone and immediately in front of the rectum. And this relationship with the rectum is taken advantage of in terms of examining the prostate, what we call the digital rectal examination. You will notice that there is a tube, there are two tubes coursing through the prostate that joins within the prostate. So the prostate is the organ at which the urinary tract and the genital tract meet. So you'll notice that tube coming from the bladder, that's the urethra, and another tube coming from the seminal vesicle, that's the ejaculatory duct. And so the urethra, the ejaculatory duct meets the urethra within the prostate. And this is where part of the semen comes from. Of course, we said that about 20% comes from the prostate itself. You'll notice also that the urethra continues right through the prostate and into the root of the penis and continues to the exterior. Because of this relationship of the urethra to the prostate, whenever the prostate becomes enlarged, it may compress or partially occlude the urethra and make passing urine difficult. Okay, so just keep this picture in mind when we discuss the prostate. So we have discussed what the prostate does. We have looked at where it is located. We see the anatomical relationships to the bladder and to the rectum, and the urethra passing right through it. Can a man live without his prostate? Absolutely. The prostate is not necessary for life, as Deacon Clive Chambers and Mr. Juridine just mentioned. They are both prostate cancer survivors. They have had their prostates removed, and they are now, I think, 11 and 18 years later, and they are alive and well and functioning well. So the prostate gland is not necessary for life. However, a man will find it very difficult, in fact, impossible to reproduce, to father a child naturally after the prostate has been removed. Okay, so now that we know these things about the prostate, let me stop sharing and let's talk about prostate cancer. So there are 3 diseases that affect the prostate commonly: prostatitis, which is inflammation of the prostate; BPH, which is benign prostatic hyperplasia, and that could be thought of simply as benign or non-cancerous enlargement of the prostate; and finally, there is prostate cancer. BPH and prostate cancer affect aging men, affect men who are getting older in life. So those 2 diseases, BPH and prostate cancer, are conditions that affect men as they get older. Prostate cancer is rare below the age of 40. But what exactly is prostate cancer? So the body is made up of trillions of cells, and these cells exist in harmony with each other, and the regulation or the turnover of these cells, or the reproduction of these cells, is finely regulated by the body. Whenever you have a change in the genetic makeup of a cell, it may cause a cell to reproduce in an unregulated fashion. And when this reproduction or turnover of the cell continues in an unregulated or unchecked fashion and continues doing so, you may have a tumor or growth forming. As the genetic makeup of the cell becomes increasingly changed and unstable, these abnormal cells may acquire the ability to invade surrounding tissues and spread to distant sites in the body, a process we know as metastasis. So a cancer, by definition, is an abnormal growth that reproduces in an excessive fashion long after the trigger that caused it, and it has the ability to metastasize or spread to other sites in the body. And it commonly metastasizes through the bloodstream, the lymphatic channels, and it can invade directly into surrounding tissues. And when the cancer overwhelms the body, that is when the patient may die. There are different mechanisms by which a cancer may cause death. We won't go into that, but suffice to say that a cancer is like a parasite, and it diverts the body's nutrients to itself and continues growing in that excessive fashion, depriving the host of nutrients until it overwhelms them and eventually causes the death of the host. So when that process starts in the prostate, that is what is known as prostate cancer. What are the risk factors for prostate cancer? Well, we said earlier that prostate cancer is a disease of aging men. It is exceedingly rare below the age of 40, and with each successive decade of life, the incidence or the frequency of prostate cancer developing in populations of men increases. So age is a risk factor, and unfortunately, we can't do anything about our age. The other risk factor for prostate cancer is race. Unfortunately, men of African ancestry, like you and I, we have the highest risk of developing prostate cancer compared to other races. That may partially explain why places like the Caribbean and Sub-Saharan Africa and the African Americans, they have twice the death rate of Caucasian Americans. So when you compare African Americans to Caucasian Americans, their death rate is twice, and their incidence is 60% above Caucasian Americans. So race is definitely a risk factor for prostate cancer. And then the third established risk factor is a family history. A family history of prostate cancer amongst a first-degree relative. A first-degree relative of a man would be a father or a brother or a sister. A first-degree male relative, of course, would only be able to get prostate cancer. So if a man has a father or a brother with prostate cancer, generally speaking, he is at a twofold increased risk. If he has two brothers or a father and a brother, he's at a fivefold increased risk. And if he has, God forbid, three brothers or a father and two brothers with prostate cancer, he is at an 11-fold risk of developing prostate cancer. Now, unfortunately, if you don't have a family history of prostate cancer, you cannot take comfort in that fact. Because the truth is, only 10% of men overall diagnosed with prostate cancer give a family history. The other 90% of men do not have a family history. So if you don't have a family history of prostate cancer, that is no comfort to you. You still have to do the necessary checks, which we're about to speak about. But it's not just a family history of prostate cancer, but the brothers and sons of women with breast cancer are also at increased risk of prostate cancer, and vice versa, because there's a gene called the BRCA gene that puts men at increased risk for prostate cancer and women for breast cancer and other cancers. Okay, so those are some of the established risk factors. Diet and lifestyle are also other risk factors. A diet rich in red meat, animal fat, processed meats, and dairy products may also increase one's risk of prostate cancer. I know my colleague, Dr. Wan, is going to be talking about prevention of prostate cancer, and no doubt he will mention diet. But I want to, because I only have 20 minutes, I want to quickly move on and speak about diagnosis. Now, we said earlier that prostate cancer occurs in men as they age. One of the main problems about prostate cancer is that when it is early, when it is still confined to the prostate, it generally does not cause any symptoms in the man. So the man is going about his normal business, feeling fine, feeling healthy, but there is a cancer that is growing in him and he's not aware of it. And that cancer that is growing in him, if it is not discovered early, it will continue growing until it eventually causes symptoms. But usually at that point when it causes symptoms, it has grown outside of the prostate, or it may have metastasized or spread. So the important take-home message from this talk is that a man must not wait until he has symptoms to get checked for prostate cancer. A man beginning at age 40 years in our high-risk population must come to the doctor and get a blood test. We spoke about the prostate-specific antigen, or PSA, earlier being an enzyme secreted by the prostate. This same enzyme, whenever there is an abnormality of the prostate, it leaks across into the bloodstream in increased amounts. And we take advantage of this by measuring the level of prostate-specific antigen in the blood. When the PSA in the bloodstream is elevated, it tells us that there is something wrong with the prostate. So this is one of the tests that we use to try and detect prostate cancer early. The other test we use, of course, is the digital rectal examination, where the doctor puts his or her gloved and lubricated finger in the back passage and feels the surface and consistency of the prostate to feel if there is any abnormality. The prostate just, it feels like the tip of the nose. It has a firm rubbery consistency. And if we find that there's any abnormality like my knuckle, then we get suspicious for prostate cancer. If the PSA is elevated or we feel an abnormality in the prostate, the man will be recommended to have a biopsy. A biopsy is where we take a pinch of tissue from the prostate and we send it to the lab for the pathologist to tell us whether or not there is cancer. If the pathologist finds that there is cancer, the pathologist will tell us what the grade or the level of aggressiveness of the cancer is. If we get a diagnosis of prostate cancer, the urologist will determine the stage of the cancer, that is the extent of spread of the cancer. Together, these two pieces of information, the grade and the stage of the cancer, along with the age and the life expectancy of the patient, the resources available to the patient, and the wishes of the patient will be used to determine what is the best treatment for the patient. I'm very quickly going to mention some of these treatment options. So if a man has a very short life expectancy and the diagnosis of cancer is not likely, prostate cancer is not likely to threaten his life, we will recommend what is called watchful waiting, where we do not monitor the man at all, but we simply tell him, if you have symptoms of prostate cancer, then come back to us and we will treat it. We do this because the man is very unlikely to die from prostate cancer, because generally speaking, prostate cancer is a relatively slow-growing cancer. It takes about 10 years from the time of diagnosis of early prostate cancer to the time it causes death. The other option for treatment is what we call active surveillance. And in active surveillance, this is appropriate for men who have what we call low risk or very low risk prostate cancer, meaning that we have made a determination that this cancer is not likely to threaten their life. However, these men have a long life expectancy, and so we monitor them very carefully to determine if there are any signs of progression of the cancer. Every 6 months or so, we do repeat PSAs and we repeat the rectal exam and we repeat the biopsies to determine if there is any progression of the cancer. If there is no progression, we continue actively monitoring these men. But if there are signs of progression, we will abandon active surveillance and then recommend one of the two standard treatments. One standard treatment is surgical removal of the prostate, what we call a radical prostatectomy. This can be done in different ways. It can be done through an open incision called a radical retropubic prostatectomy, in which we completely remove the prostate. It can be done using laparoscopic or keyhole surgery, and it can be done with the aid of a robot called robotic assisted laparoscopic radical prostatectomy. So these are the three main ways of removing the prostate. The other main treatment option is radiotherapy, where we focus high energy radioactive beams on the prostate to kill the rapidly dividing cancer cells while sparing the normal cells of the prostate. And this will effectively eradicate the cancer. We can also implant radioactive seeds in the prostate in appropriately selected patients. So these are the two different categories of radiation, broadly speaking: external beam radiation, or what we call implantation of radioactive seeds, or brachytherapy. Okay, so that's the treatment for early prostate cancer. There are other treatments as well, but those are the main treatment options. I have 1 minute left, so let me just very briefly talk about some of the potential side effects of treatment of early prostate cancer. So there are two muscles that control the urine, and during the removal of the prostate, one of those muscles is removed. So because one of the muscles of the two muscles is removed, men may notice that immediately after surgery, when the catheter that we put in is removed, they may initially leak urine. The fact is, the vast majority, in fact, 95% of these men will generally regain control of their urine within a year. What we call, they will regain continence, or the ability not to leak urine within a year. The other side effect of surgery is erectile dysfunction. And this is because the two nerves, or pair of nerves that supply the penis, are very closely associated with the prostate. We routinely spare these nerves at the time of surgery unless there is an indication that the cancer is outside of the prostate and encroaching on the nerves. The fact is, once we spare the nerves and the men had good erectile function before surgery, generally speaking, over a period of up to 18 months, the function of the nerves will recover, and the men will recover their erectile function. Okay, so those are the two main side effects of surgery that men are usually interested in and want to know about. If a man presents with late prostate cancer, then the treatment is usually hormone therapy, where we deprive the cancer cells of testosterone and cause them to shrink or involute, no matter where in the body they are. And men may experience an enhanced life expectancy because we do that. But essentially, if you present with advanced or metastatic disease, eventually the cancer is going to learn new ways of circumventing the treatment that the man is getting. And a stage known as castration-resistant prostate cancer will be entered, which essentially is a terminal phase of the disease, although we have improved treatments for even this phase. I'm going to stop here. I think my time has expired, and we know I'm going to turn back over to the moderator, Deacon Clive Chambers.
Thank you very much, Professor Aiken. Very insightful and very interesting presentation. I just want to remind those who are just joining us, this is a webinar put on by the Jamaica Cancer Society and the Brothers United Against Prostate Cancer, which is a support group for persons who have contracted the cancer and might have had surgery, and maybe not even had the surgery yet, but just need support to find out, and we can help you through the process. Again, I want to thank Professor Aiken for his very insightful and interesting presentation. I will now introduce to you Dr. Robert Wan. Dr. Wan attended KC from 1957 to 1963. Upon graduation, he was awarded the Caribbean Cement Company Scholarship for Medicine and graduated from the Faculty of Medicine, UWI, Mona, in 1970. He later attained a postgraduate degree in urology in Canada in 1976. He's a past president of the Jamaica Urological Society of Jamaica. Dr. Wan has membership in the Medical Association of Jamaica, the Caribbean Urology Association, Société Internationale de Urologie, pardon my French, 1994, and the Royal College of Physicians and Surgeons of Canada. He's also a corresponding and international member of the American Urology Association, an assistant lecturer in the Department of Surgery at UWI. He has also co-authored several papers on prostate cancer. He currently has a private practice at the Winchester Business Center in Kingston and is chairman of the Kingston College Choir Committee. I will now hand you over to Dr. Wan to give us a talk on, can prostate cancer be prevented? Over to you, Dr. Wan.
Okay, good day. I have been asked to address the question of prostate cancer prevention, and I would also like to discuss treatment towards the end. Now, we know that prostate cancer incidence is high in the Western countries like the USA and low in the Far Eastern countries like the Asian tigers. But after migration to the United States, subsequent generations of Asian men increase their risk of prostate cancer over those who stay behind in the Far East. We also know that African Americans have a higher incidence and mortality from prostate cancer in the USA than white Americans. In addition, men who have a brother or father with prostate cancer have a greater chance of developing the disease than the general population. One interesting familial risk is the so-called breast cancer gene, also known as the Angelina Jolie gene, because she had prophylactic mastectomies a few years ago. It turns out that men who have this gene are also at increased risk of prostate cancer. In fact, one man in the United Kingdom had removal of his prostate gland because of this. So from these simple observations, we can postulate that there may be environmental risks and also genetic or hereditary component to a risk of developing prostate cancer. Of course, there are things outside of our control, like the increased risk of cancers among the first responders to the bombing of the World Trade Center in New York City 20 years ago, or the increased risk of those men exposed to Agent Orange during the Vietnam War, which was much earlier. But what can we do to lower a risk? The obvious ones are diet and lifestyle changes. I will list some of the dietary recommendations for prostate cancer prevention. And please note that these diets are also helpful for prevention of heart disease. The main aim is to reduce consumption of animal fats, which include dairy products. The main source of our animal fats is actually red meat. So one of the commonest questions I am asked is pork red meat? The short answer to this is that red meat is meat from any mammal. So that leaves us with the option of eating white meat, which for our purposes is really chicken and fish. Of course, you may even opt to have mainly a plant-based diet or go full vegetarian. Men on these diets have a lower PSA level than the general population, which means that they are less likely to develop prostate cancer and less likely to have a prostate biopsy. Men with early prostate cancer who take a plant-based diet actually have a less likely chance of their cancers progressing than men who don't. So these are what some of the studies have shown. But plant-based diets are not always healthy. We divide them into healthy and non-healthy plant-based diets. So a healthy plant-based diet would include things like beans and legumes for your proteins, whole grain carbs, such as whole wheat, ground provisions, fruits and vegetables, especially tomatoes, and so-called cruciferous vegetables, which are broccoli, cauliflower, cabbage, and pak choy. Non-healthy plant-based diet, on the other hand, would include sodas and sweetened drinks, and of course, other sugary foods, and refined starches such as white flour and white rice. Now, please note, red meats cooked at high temperatures produce cancer-causing compounds which we call carcinogens. Those red meats that are grilled until they are charred are especially harmful. So just be careful with those steaks and jerk pork. Processed foods such as bacons and sausages are harmful and should be avoided. In fact, they have been labeled as carcinogens by some authorities. So what about acne? Big question. We have looked at this. I found no evidence that acne causes prostate cancer. So I have no objection to acne and saltfish. But please remember that a low salt diet is recommended, so go easy on the salt. And if you have it with your corned pork, actually the pork may be more harmful than the acne. So the next lifestyle management you should consider is exercise and avoid obesity. This greatly improves your cardiovascular health, and weight reduction actually helps reduce your risk of prostate cancer and also your risk of developing diabetes. So how much exercise should a guy do? Maybe 30 minutes of brisk walking 5 days a week. Most of us should be able to walk 2 miles within 30 minutes. That's only 4 miles an hour. So there is absolutely no need to train like Usain. Okay, what about vitamins and supplements? I don't think it's realistic to expect vitamins to prevent prostate cancer. In fact, some studies have shown these to be harmful, especially vitamin E and selenium, which were thought to reduce the risk of prostate cancer, but may actually increase the risk. So, saw palmetto. Again, I don't think that saw palmetto prevents prostate cancer. In fact, there is no data to suggest that. And there's also no claim by the companies that manufacture saw palmetto products that they are going to prevent prostate cancer. So the other question people ask is, what about zinc? I know it's sold as supplements, but again, there's no evidence that this prevents or treats prostate cancer. And I don't recommend that you take zinc preparations. So what can you take? Maybe a daily multivitamin, that's fine. But try to avoid megavitamins. So there are many daily vitamin preparations. There are some that are well known. I won't name any brands, but they are sold and there are different varieties and some cost a little bit more than others. Okay, so we take stuff ourselves that we don't buy in the health stores or pharmacies. What about guinea hen weed? Now, I have not seen any evidence that this prevents or it treats prostate cancer. So I cannot recommend this. However, I don't prevent anyone from taking this if you are so inclined. Same goes for soursop and soursop tea. Okay, coffee and tea. These are actually good. So studies have shown that drinking several cups of coffee daily actually may improve your life expectancy. It doesn't seem to be as many studies done on tea, but theoretically, tea should have a beneficial effect. So should I drink? Well, and if I drink, how much? We're talking about alcohol. So if you're going to drink, moderate drinking means that men should limit their intake to 2 drinks of alcohol every day and women to 1 drink. So what's a drink? Well, it's a shot of rum, a shot of whiskey or vodka, or a pint of beer or stout or ale. Now, we're not recommending that you actually go out and drink, because if you don't have to and you can abstain, that's perfectly fine. So in summary now, 1, you should reduce animal fats. 2, avoid processed foods, especially bacon and sausages. 3, increase intake of fruits, veggies, especially tomatoes and cruciferous vegetables. Increase whole grains, legumes, nuts are great. Ground provisions are great. 4, try not to get overweight. Obesity is not good for your prostate, for you, and for your sugar control. 5, exercise is great for your heart. There isn't much data to suggest exercise will prevent prostate cancer, but it does it no harm, and it actually increases your overall health. Avoid alcohol or drink moderately. And lastly, do not smoke. So, if you do all the above, will you ever get prostate cancer, or can you never get prostate cancer? You may reduce your risk, but you still can get prostate cancer. So you still need to be careful. So you should still check your PSA level, as you may have heard, and get your DRE test done. I believe that's about the best we can do right now in terms of screening. So if you do all of these and you get your biopsy, and the biopsy shows a cancer, we want to know how bad it is. That's called aggressiveness. So we look at what's called a Gleason grade. A Gleason grade of 6 is not so bad. It's probably favorable. But if it goes up 8, 9, and 10, that means aggressive disease. So we have to be careful there. But if it's aggressive or it's not aggressive, has it spread? So that means that we look at the stages. So we want to be at an early stage, if at all. And we don't want to be at a late stage. So most of us know what stage 4 generally means. For the public, it usually means that the cancer is widespread. So we don't want to be at a stage 4. We prefer to be at a stage 1, and better still at a stage 0. How do we know what stage we are? Well, we look at the PSA levels and we do imaging studies. So the imaging studies that we do for men with prostate cancer, as you may have heard, maybe CAT scans, MRI scans, bone scans, and now we have this thing called a PET scan. And we would prefer, if you have low PSA levels, maybe no prostate cancer at all, and if you do have it, negative imaging studies. The idea being that if we do find a cancer and it is minimally aggressive, then maybe we could eradicate it with treatment, and the treatment may actually be surgery or radiation. For surgery, the operation is called a radical prostatectomy. That's something that's done fairly often in Jamaica. There is an option of doing radical prostatectomies using a so-called robot. Unfortunately, the robot is terribly expensive, so that I don't think we'll be able to provide a service in Jamaica in the foreseeable future. Or we can never tell, maybe we'll get a benefactor. So if your urologist says maybe you should do a radical prostatectomy, you say, I don't like the idea of surgery, what else is available? You could look at maybe doing radiation. And radiation is using high dose X-rays. It's generally given Mondays to Fridays maybe about 15 minutes each time on the machine, but it goes on for about 7 weeks. You don't like the idea of radiation? There's another type called brachytherapy. And they will term this seed therapy, where radioactive particles are actually inserted in the prostate gland. That's a one-off surgery, and you can go home the next day. Now, if the cancer is not very aggressive, maybe you don't need to do surgery or radiation. Maybe we could just watch it. So this is something called active surveillance, and it is done a lot. How do we do active surveillance? We find the right candidate. This is a gentleman who has a tiny amount of prostate cancer. It's not very aggressive. We don't think it's spread anywhere, and we think he could live at least 10 years without us having to do any treatment. And there actually are men who have lived 10 years or more and not have treatment, and their cancers are stable. But how do we know that it's stable? Well, you have to check the PSA fairly regularly, and we do the DRE fairly regularly. This means once or twice a year minimum. And in some cases, we do a repeat prostate biopsy to see if the cancer has got worse. And nowadays that we have this MRI machine, we can do MRIs on a more regular basis. I do want to warn you that not all men who are in this program will go through to the 10 years. In fact, a significant amount of men after 2 or 3 years will say, look, this thing is driving me crazy. The PSA actually went up maybe from 4 to 5, and I don't like this. This may mean that my cancer is getting worse. Please take out my prostate. Or his urologist may say, look, I don't like how your prostate feels this year. It didn't feel this bad last year. You should take out your prostate. So there is a certain rate of conversion from active surveillance to surgery or radiation among the men that we do put on this program of conservative management. But a large portion of them are able to continue this non-surgical, non-radiation treatment for many years. And it's probably more suitable to the older guys, and of course, the guy with a cancer that's not very aggressive. Now, in my practice, unfortunately, most of the cancers I see have already spread beyond the prostate. So if it's just outside of the prostate and hasn't spread very far, we may still be able to offer surgery or radiation. But what if it's spread very far? What if it's gone to lymph nodes which are outside of the pelvis, not in the region of the prostate? Or worse, it's gone to the bones, which are definitely far removed from the prostate. Unfortunately, prostate cancer seems to spread to bones fairly often, and this could be disastrous if the spinal cord is involved. Each year, we see men who develop paraplegia because of spinal cord compression due to prostate cancer. The tragedy of this situation is that some of these guys may never walk again, even if we treat their cancers. Now, for men who we cannot offer curative treatment, we still offer medications to prolong their survival and improve their quality of life. The basis for this is called androgen deprivation therapy, which will reduce the production of testosterone or male sex hormone. And this is done in a man. If this is done in a man with prostate cancer, his cancer actually shrinks and his PSA settles down. And if he's having pain, the pain is relieved. Now, the earliest form of this treatment was actually surgical removal of the testicles or castration. Fortunately, we really perform this procedure because we now have medications, and these can trick the body into shutting down testosterone production. We also have medications which block the action of testosterone, if any is still being produced. And furthermore, we have newer drugs based on this line of treatment. They are much more effective, and we use them if first-line drug treatment fails. Unfortunately, some of these drugs are expensive, and for some of us, may be prohibitively expensive. Okay, what about chemotherapy? A lot of patients are very worried about chemotherapy because this conjures up all sorts of terrible side effects. But we don't use chemotherapy as a first-line treatment. but for some patients, it is very appropriate. And we will refer patients who need chemotherapy to so-called oncologists, medical oncologists, or oncology hematologists. And they are aware of all the possible side effects. They always act in the best interest of the patients, and they will counsel you and decide what is appropriate. Okay. You don't like chemotherapy, don't like hormone therapy, androgen deprivation therapy, you don't like radiation, you don't like surgery, but there's a cancer there. What else could you do? I would like to mention complementary and alternative treatments. Now, the former is where you take something in addition to our treatment, and the latter is where you totally substitute another treatment for ours. It has been shown, unfortunately, that patients who pursue these pathways have a greater risk of dying from their cancers. The reason is felt to be it's because they refuse surgery, radiation, chemotherapy, and hormonal treatment, which are offered by conventional medicine. So my advice on this form of therapy is that if you do this and you ignore medical advice, then you do so at your own peril. So what about the future? What if none of what we are doing works? There are other treatments, and some of them are being developed even as we speak. One very interesting and novel way of treatment is to attach a radioactive compound to a substance called PSMA. And this we know will target prostate cancer cells, no matter where they are. We first would have to show on a PSMA scan that there are cancer cells which are amenable to this treatment. We do have such a test done in Jamaica now. Now, this treatment of PSMA-linked radiation is being done in Europe and Australia, and I believe it will soon be available in the USA. It is not magical, but it does offer some hope for somewhere there was none. We still don't have a vaccine for this disease, but who knows when this will be available. Every week we learn of new developments, so there's always hope for the future. Finally, my takeaway message for you is that if you pursue a healthy diet and lifestyle and do your prostate screening, and especially if you're in the age group which is at risk, and you do not ignore your advice, then you have done just about all we can ask of you. Thank you.
Thank you very much, Dr. Wan, for that very interesting presentation. At least it shows some options that we can use in our approach to being treated for prostate cancer. Thank you very much again for your presentation. Just want to remind the attendees that, and we thank you for joining, that you can post questions in the question Q&A section of the webinar. At the bottom of your screen, you'll see something to the left of the chat, the Q&A. You can post your question there, so we will be able to ask our panelists to answer some of these questions directly. I will now move on to Mr. Noel Codlin, who is the insurance advisor for Garden Life Insurance Company. And that is a very important point as well, to find out what sort of insurance is provided for persons who have prostate cancer. And that's very important because it's a costly thing to do surgery, and all the treatments can be very costly. So it's very important to find out how can the insurance companies help in our treatment of prostate cancer. And it will help us to rest a little easy to know if the insurance companies do offer support for treatment. Over to Mr. Codlin.
Thank you very much, Mr. Moderator, and good afternoon to all the panelists and the participants. Interestingly, myself, I've been an insurance advisor for the last 20 years, and I have had to claim on my own insurance because some years ago I was diagnosed with prostate cancer. contrary to all that doctors highlighted and said, I had none of the contributing or normal things that they look for. Didn't happen to me. My family has no such thing. I was relatively young, but yet still I was diagnosed. But the good thing is that I was adequately secured, adequately insured and covered, so that I'm here today because of one of those reasons. Because one, I was able to identify it early, and two, the fact that I had sufficient funds to look after my treatment gave me a certain level of peace of mind and contentment, so that I'm here today to share in this forum. Earlier on, Michael had alluded to the fact that the Brotherhood was able to supply all kind of support, but the only support that they were not able to supply was that of financial. And so it comes to the matter of insurance. And persons wonder at time if the insurance company will in fact be able to pay out monies. I don't have the exact figures with me, but one of the things that has been happening in my own experience, the company has been paying out claims in excess of millions of dollars to several persons, young, old, and middle-aged, male and female, to look after their own cancer. The fact of the matter is, though, that persons who are diagnosed oftentimes get questions. Can I get some coverage? No, I was diagnosed last week. No. The fact is, you have to be insured prior to being diagnosed with cancer. Insurance, we always tell persons, are for healthy people. It's not when you're at death's door that you can get insurance to look after your illness. No, you would have had to have it in place. And as one famous Jamaican says, it takes cash to care. And my last, some figures that I had seen a couple of weeks ago, it required about, for Jamaica, about somewhere in the region of $11.8 to $12 million upon diagnosis, because as the doctors just all highlighted, there are several courses of treatment, but all of these come with a fairly heavy price. So therefore, we must ensure that we have sufficient coverage. So we at Guardian, we have two plans that are available to persons to look after their illnesses. And I want to just quickly mention them this afternoon. One that we look at first is what we call the ultimate provider. And it's sold to persons ages 20 to 60, nearest birthday. And each person, the minimum that can be gotten is 30 million, 3 million, and the maximum is $50 million worth of coverage. These, in order to receive the coverage, persons would have to go through a rigorous medical to ensure that, as we always say, you look good on the outside, and we want to ensure that you look equally well on the inside. It covers not only cancer, but 22 other illnesses. At the end of the day, if we do what we call an optional increase every year, this coverage can be maximized at 100 million. So you start at 3 million, which is the minimum, and the maximum available is 50 million. But over the years, if you opt for the optional increases, your coverage can be doubled. So you can move from 3 to 6 or from 50 to $100 million. So it requires of you to get a medical to be done, and then when all of this is completed, you'll be issued your policy. Upon diagnosis, the company then requires that you produce the policy contract and certain reports that the doctors will be able to supply, and more so the exact date of your diagnosis, because there is a waiting period of 90 days after you have been, if say for instance you have been, the insurance comes into force on day 1, there's a waiting period of 90 days to ensure that nothing happens, so that after the 90-day waiting period is now completed, then whatever the diagnosis, whenever the diagnosis then comes in, your claim will be settled promptly. And the settlement of the claim is normally dependent on us receiving all the necessary evaluation, all the necessary studies, the histology reports, etc., which will will form a part of the claim process. So that is one of the critical illness plans that we have. We call it the ultimate provider. As I said, it's issued between ages 20 to 60, and your initial sum that you purchase can be doubled over a period of time. Secondly, that we have one that we call a non-medical one, which we call the Guardian Care Plus. It covers 10 illnesses, and the maximum coverage on that policy is $15 million. For this policy, however, there is no medical requirements. In that, when I say so, I mean that you wouldn't have to do a medical in order for you to receive same. However, if you have certain pre-existing conditions and you don't disclose it at the beginning of you signing of the forms, it can cause an issue at the claims period. But again, it's issued to you, and if nothing occurs, if you don't claim on the policy, it covers you up to age 75. If there are no claims that are paid out, you then receive all the premiums that you paid over the period of time. If, however, you die from the illness and you are not able to claim, your beneficiary will get whatever you are insured for. Equally, if you die outside of the 10 covered illnesses under the Care Plus plan, the beneficiary will receive all the premiums that you pay. And if you live to see age 75, again, all the premiums are refunded to you. But to backtrack a little bit, basically, yeah, that is what it is for the Guardian Care Plus. But backtracking a little bit to the first plan that I highlighted, the ultimate provider. Before age 75, one of the benefits is that the basic sum assured and whatever your investment is, because this policy also carries a minimum investment of $1,000. Where death does not occur within 30 days of the event, the basic sum assured less all the indebtedness is payable on death or upon the first diagnosis of any of the events. At age 75, if no critical illness claim is made, then 50% of the sum assured is paid at age 75. So to break that down a little, say for instance at age 75, you had a coverage of $20 million and you're still alive, and you did not claim on the critical illness benefit. 50%, which is $10 million, would be paid to you while you're still age 75, and then the remaining 50% will go on to carry on up to age 100, which will now form what we call more or less a life insurance coverage. So there is cash that can be had, but again, I emphasize, in order for you to receive coverage for cancer, you must present yourself far before your cancer is active. So while you're alive and well, you must speak to an agent and allow the person to carry you through the whole process of what it takes to have your own critical illness benefit. Critical illness benefits are essential nowadays because of the prevalence. And as the doctors highlighted, Jamaica and men of African descent have far more cancers than what is happening worldwide. So therefore, it is essential that I speak to every man or woman that is here today on this forum is an essential part of your arsenal against illnesses, because a lot of times we see people who are discouraged when they are diagnosed with whatever illness, say for instance cancer. They're discouraged and they even die even quicker because the fact of the matter is that they had no money to take care of whatever the necessary treatment was available. So I encourage persons to seek out, if you don't have an advisor, just call the company and they will put you onto an advisor to further explain all the benefits that can be had from having an insurance policy that will be able to pay when the diagnosis comes. As they say, you never normally need an umbrella until it starts to rain. So friends, that's my encouragement to you all. Let's get busy and ensure that our lives remain viable as we seek to more or less take care of ourselves in these troublesome times. Thank you.
Thank you very much, Mr. Codlin, for that very important and informative presentation about insurance for our wellness and our health. Thank you very much for your presentation. Now I want to move to the question and answer period. Some persons have posted questions in the Q&A. And I would ask, these are addressed to, this first one will be addressed to any two of our doctors to answer. Person asks, does blood type have a bearing on prostate cancer? Does blood type have a bearing on prostate cancer?
I'm not aware of any evidence, Clive, to suggest, Deacon Clive, to suggest that your blood type either increases or decreases your risk of prostate cancer. So no, I'm not aware of any such evidence. I don't know if Dr. Wan has things differently, but I'm not aware of any evidence.
No, I don't, and I did reply. I did reply in the box that all blood groups are susceptible, so we're all at risk.
Yeah. Well, I just wanted to bring it up front to everyone. If someone is having that thought in his mind, you might help to clarify it. And the other thing that was in the group, and I think you have answered, what is happening with barley moss in the management of prostate cancer?
Okay, I think that they meant ball mass.
Ball mass. Okay.
I think that is what it meant. I know there's a preparation that's available, but there's no data to support its use. So it has some theoretical possibilities, but there are no studies to show that it ever helps. It helps. So it's like the take on guinea hen weed. My advice: sure, you can take it, but if we do the radiation or do something else, do that too, please.
Yes. Okay, no, thank you very much for that response, because I do know there are persons who are resistant to having any medical treatment. They say they'll go natural, and so it's up to them to decide. I tell people when they ask me, I say, look, I'm not a doctor. Speak to your family, and then your family can guide you. I can tell you what I went through, but I will never try to give you medical advice because I'm not a doctor and I have no expertise in that area. So what I do, advise them to speak to your doctors and speak to your family. Those are the ones who will help you to make your decision ultimately. Another one was, what are the current costs of screening for prostate cancer?
Okay, so it depends on where it is done, Deacon Clive. So as our participants may not know that the Jamaica Cancer Society offers screening at a deeply discounted rate at its office on Lady Musgrave Road. The urologists volunteer their time free of cost, and so when you go to the Jamaica Cancer Society, you will have a urologist examine you, and the Jamaica Cancer Society will have your PSA done at a deeply discounted fee. I'm not sure what the fee is. I think it may be just a couple of thousand at the most, but that would be much less than if you were to go to a private doctor's office, which may cost maybe as high as 15,000 or more. So the Jamaica Cancer Society is available, but any doctor can screen for prostate cancer, any physician. So it depends on the patient's pocket. They can go to their primary healthcare center as well. Health centers, I know the government, the Ministry of Health and Wellness has a thrust for prostate cancer screening to be done in the primary healthcare clinics. So it depends on where it is done. The cost may vary quite significantly.
Thank you, Dr. Aiken. I see where Shulian has put up that it's $3,500, which includes the cost of PSA at the Cancer Society. As a follow-up, someone asked the question, is it sufficient to do a PSA only and not the DRE? I know, the homophobia in Jamaica, a lot of our men hate the point about doing a DRE. And just to point out, Dr. Aiken, that I was diagnosed from my primary care physician and then referred to you. And what I do say to some of the men, if you're afraid of a male, go to a female doctor. Their fingers are usually smaller. And you may feel more comfortable with a female rather than a male doctor. So that's a possibility as well. Could you answer that question, Dr. Aiken? Is it the PSA only without the DRA? Is that recommended?
So we will not turn away any man who insists that he only wants a PSA done. Having said that, the tests are complementary, meaning that you get information from the one test that you can't get from the other. And so we recommend that both tests are done together. There are patients who may have a normal PSA, and when you examine the prostate, you may find an abnormal nodule. And not only does an examination of the prostate tell you whether a nodule is there or not, but it helps to determine the stage of the cancer. So if you have a nodule that is palpated and it does turn out to be prostate cancer, one of the things that we determine is the extent of that nodule. How much of the prostate is that nodule involving? Is it going outside of the prostate? Not only that, but when we examine the prostate, we, of necessity, feel the rectal wall. So if there's a colorectal cancer is a very common cancer in Jamaica as well. And so it is said if the doctor doesn't put his finger in, he puts his foot in, because it's a compromised examination of or evaluation of the patient if you do not do a rectal examination. So I know it's a long-winded answer, but the short answer is that both tests are necessary, but we're not going to turn away a man from screening if he insists that he's only going to do the PSA.
Okay, thank you, Dr. Aiken. There are two persons with hand raised. Evelyn Ellis Brown, would you like to post your question? Make it short and sweet to any of the two doctors or anyone in the panel that you would like to raise a question to.
I think that hand was an accidental raised, Doc. But since I have the opportunity, if you're at stage 1 prostate cancer, is that something that can be stabilized or probably reversed?
Dr. Wan will probably take that question.
All right. Well, I'm sure that our answers will be virtually identical. It's unrealistic to expect that a cancer is going to disappear. So what I did mention earlier was that for some cancers, if we think that they don't look like they're going to go very fast, that they, in other words, they are not aggressive, and we know from the test, or we think we know from the test that they're very early, maybe we could monitor it. Okay. So it's a kind of personal decision between the guy who's involved and his family and the urologist. Is it aggressive, and therefore should I remove it? Is it not aggressive? Maybe I could watch it. And then you do all you can with your lifestyle and diet, etc. But it's not realistic to expect that it's going to go away. So if you're not going to do anything other than the active surveillance, which is reasonable, we just need to be careful in that situation.
Thank you, Dr. Wan. Maybe this one, I don't know if Michael could answer this one. How important is group and family support for a man diagnosed with prostate cancer? Could you take that one on, Michael?
Okay, Deacon Clive, I think I responded in the chat for well, not an issue.
Yeah, but this is maybe a general question that people might want to know.
Sure. No, family and group support is immeasurable. I think it really is at the phone. Well, first of all, I'd want for the person recently diagnosed to just understand it is not a death sentence, right? And especially in the case where you're doing screening and you've caught it early. Even as both the clinicians have said, at whatever stage it's caught, there is some level of hope, right? So that's the first thing. And we have to stay positive. And it is the core group, your family, your close friends that know you well, and they are very, very important in having this very positive response. You know your friends. If you have a problem, you know who to go to about specific things. If you know the person is always somebody that is always taking the negative view, stay away from that friend, please. There is no shortage of information, but please let us not deal with it like how, don't follow the hype and the social media. Go to your doctors, the trained medical persons, and speak with them. I can't overemphasize that. If you're even having a difficulty, it doesn't mean if you're having a problem with your bladder somewhere that it necessarily means you have prostate cancer. I do need to make that point. There are a number of things that can be going on. But the important thing, gentlemen, well, ladies for the gentlemen, because I know the ladies check, is to have a checkup even once a year once you get to age 40. And listen to your body. Don't fool yourself. But the support of friends and family, I can't begin to tell you how much it's intrinsic, it's immeasurable. It's just something that you cannot do without. You should not do without. I hope that answers the question adequately.
And I want to say ditto to all you have said, Michael. I've been through it myself, and my family and friends and church community gave tremendous support, which made it much, much easier for me. Okay? And thanks for your answer. Let me see. Now, there's another question here that says, what are the side effects, if any, on a reduction of testosterone? The two doctors.
Maybe Dr. Aiken.
That treatment, yeah.
Maybe Dr. Aiken can take this one.
Okay, so I assume the person means a side effect of a reduction in testosterone caused by the treatment of advanced prostate cancer. So as Dr. Wan mentioned earlier, one of the main ways of treating advanced prostate cancer when it has metastasized is to deprive the body of testosterone. And he did mention in the early days, we would castrate men or remove their testicles, but thankfully we don't have to do that anymore. There are medications that bring about what we call castrate levels of testosterone, or the same levels of testosterone in the body that would have occurred if a man had his testicles removed. Testosterone is a very important hormone, but let me first of all say that the reason that we do this is because prostate cancer is what is called a testosterone-dependent cancer. It thrives and multiplies and spreads in the presence of testosterone. And when it is deprived of testosterone, the cancer shrinks, no matter where in the body it is. In the vast majority of patients, the cancer will, what we call, involute or shrink. And the man will experience an improvement in his symptoms and increased life expectancy. However, testosterone does have some important roles in the body. It is one of the most important roles, and I think Jamaican men would agree with this, is that it is important for maintaining libido. So interest and desire for sex is very much related to the testosterone level. So one of the side effects a man may experience after going on the medication for advanced prostate cancer is that he may find that he doesn't have much in the way of interest and desire for sex. He may also find that his erections are very difficult to get because a certain background level or permissive role of testosterone is necessary for normal erections to occur. So he may find it difficult to have erections. He may notice that he gains weight because testosterone is associated with maintaining a lean body mass. So after medication is given to reduce testosterone levels, a man may find that he gains weight especially around the waist, which, there is now an increased emphasis on what we call cancer survivorship. So the urologist will make efforts to have the man increase his exercise and watch his diet and try to minimize the effects of the weight gain. The man may also notice that his memory might be slightly impaired, or he may have other cognitive effects related to a reduction in the testosterone level. You may find also that he doesn't have that get up and go vitality. But the truth is, in the vast majority of patients in which we give this medication to reduce testosterone levels, the patients feel a lot better because the pain and suffering from the cancer is usually relieved. So in the particular patients who benefit from reduction in their testosterone levels, the benefits far outweigh the negative effects, because the patients feel a lot better as a result of the shrinking of the cancer. Okay, so there are other effects as well, but those are some of the main ones that would be of importance. There's one more that I should mention, and it is hot flashes. And this is quite bothersome. Depending on the type of medication the man is given, he may have what is known as hot flashes, where he suddenly perspires and becomes drenched with perspiration. And this can be particularly bothersome, but there is medication that we can give to counteract that effect. All right, so I'm going to stop there.
Thank you, Professor Aiken. This one is for the insurance, Mr. Codlin. It says, is it legal to make a claim for 2 insurance companies for the same diagnosis?
Yes, you can have insurance with 4, 5, 6 companies for the same condition. Nothing is wrong with that. It's entirely legal. Okay,
thank you. One other question is, you had mentioned it earlier, but could you repeat it? Is there an age limit for applying for these 2 insurance policies that you spoke about? Is there an age limit? And if you reach a certain age, you can't apply anymore?
Yes, age 60.
60, okay. All right. The other question is, if you have prostate cancer and you are considered cured, been treated and may be considered cured, can you then apply for health insurance coverage? Is that allowed?
Yes, it's allowed. The company would require all tests done by the medical practitioner since the diagnosis and since the elimination of the cancer. So yes, it can be done, but medical evidence would be required.
Thank you, because I have known of persons who have had difficulty in getting coverage afterwards, even though the person said, do not cover me for prostate cancer. And they have been up front on the phone, because what's another thing you raised about being honest in your application for coverage. If you're not honest, then you can be kicked off. But
right. One other thing though, it is normally recommended that you don't apply for any kind of insurance until 5 years after.
Okay, I see. Okay, thank you. Thank you for your answers. This one to Dr. Aiken. You had mentioned earlier about the number of your family, relationship with family. In my case, there are 6 boys in my family, and I think I've shared this with you already. There are 4 of us who have had prostate cancer. What is the implication for our children, our boys? And as you said, there's a relationship with women as well. What are the implications for those?
Okay, Clive. So there's something known as hereditary prostate cancer, which is a subset of familial prostate cancer. Familial prostate cancer just simply means that within your family, there is someone who has had prostate cancer. So it's more than one person. But with hereditary prostate cancer, the definition is more limiting in that it's prostate cancer in 3 successive generations or prostate cancer occurring in 2 brothers below the age of 55, or in 3 brothers, regardless of age. So in cases of hereditary prostate cancer, there is usually a specific gene or genes that are conferring tremendously increased risk of prostate cancer. We mentioned one such gene earlier, which is the BRCA gene, which increases your risk not only of prostate cancer, but breast cancer. But there are other genes. There are over 300 genes that have been discovered that may be related to increased risk of prostate cancer, and some of them specifically in men of African ancestry. What does it mean? It means that beginning at age 40, you would have to ensure that your boys are educated about the importance of screening for prostate cancer. I just want to mention very briefly a story here, Clive. There was a patient of mine many years ago, he has gone more than 10 years now, who came to me when he was in his 30s. And his father had been diagnosed with prostate cancer and in fact died from prostate cancer. I can't recall at what age his father was diagnosed, but it was, I believe, in his 60s. And I mentioned to my patient that, he didn't need to come so early. I would recommend that he returns at age 40. But he insisted on being screened, and so I went ahead and screened. And lo and behold, we found that he had prostate cancer. He hadn't yet started a family and he wanted to do so. So based on the fact that it was a fairly low risk prostate cancer, I encouraged him to start a family, which he did. And we removed his prostate after he had his first child. I just mentioned that simply to say that we're not going to turn away anybody in their 30s on an individual basis who may come with a strong family history of prostate cancer. But as a policy recommendation, the age is 40 and remains at 40 because prostate cancer is quite rare below that age. But certainly, again, we're not going to turn away anybody who has a very high or strong family history, as in your case, Clive, where several of your brothers have prostate cancer, or anyone else for that matter. We won't turn you away. We will see you before age 40. Thank
you, Doc. Another question. Someone asked me, not in this forum, but so I remember met a lady who said she had a history of breast cancer in her family, so she took a decision to take off her breast because she knew that she was a high risk. And somebody asked me the same question about the prostate. Would it make sense for you to take the prostate out as a precaution? Like in my case, with so many of us would it, if one of them were to ask me, what would be the advice? And I usually tell them those sort of questions I cannot answer. That's for the medical doctor. But just for anyone else thinking about that in this forum, what would your advice be?
It's for Bobby. That's for Dr. Wan.
Dr. Wan.
Personally, I would not take out somebody's prostate just because his brother and his dad had cancer. I know that people have asked this question time and time again. And my advice would be, okay, we normally start at 40, but if, like what Professor Aiken said, you come in at 35 and you say, I'd really like to start now. Okay, let's start now. But in terms of removing somebody's prostate, I would only do it if we did a biopsy and the biopsy showed that there was cancer there. That would be my personal advice. And I think most urologists would go along with this view.
Okay, thank you for that.
I completely concur with that.
Well, as I said, I would send them on to the doctor. I would not take that decision for them. Certainly not. I don't see any more questions. This has been a very, very interesting and very important forum for prostate cancer. And I would like to extend my thank you to the Jamaica Cancer Society and to the Brothers United Against Prostate Cancer for taking the time in this Prostate Cancer Awareness Month to make this available to many. What I'm disappointed about is that more persons did not come on, and it was advertised a lot, I think. I sent it to all my churches, and I'm a little disappointed that more men and women did not come on. But the good thing is that the video will be available on the Jamaica Cancer Society YouTube channel, so others can join it at a later date. So those of us who know others who may have wished to come but might have forgotten, we could spread the word to go to the YouTube channel, the Jamaica Cancer Society website, and they'll be able to view this video production. I want to thank individually all the panelists, starting with my brother, survivor, Michael, and to our guest, Mr. Noel Codlin, who is also a survivor, and Professor Aiken and Dr. Wan, and everyone, all the attendees and especially those who were brave enough to ask questions. Thank you very much, and I hope you have learned a lot from this session. I have certainly learned more, even though I'm an 18-year survivor. Knowledge is never complete. We are always learning something new. And that's the good thing about medicine. Medicine is always advancing, so we need to keep up abreast with it as well. And so thank you very much all, you all, for making this a wonderful afternoon. Thank you very much.